Good morning. Welcome to another interesting session of Quest. The topic for today is implementation science in nutrition support. I welcome our dear Tom Sachin, chaplain, to lead us in prayer.
Shall we all stand for the prayer? പിതാവിനും പുത്രനും പരിശുദ്ധ സ്തുതി ആദ്യമുള്ള നീക്കം തന്നെ ആമേൻ. സ്വർഗസ്ഥ പിതാവേ, അനദർ തേഴ്സ്ഡേ, പുതിയൊരു വ്യാഴാഴ്ച അങ്ങനെ ഞങ്ങൾക്ക് ദാനമായി തന്നുവല്ലോ. ഇന്ന് ഈ സെഷൻ ലീഡ് ചെയ്യുന്ന ഡോക്ടർ കൃഷ്ണൻ അതിനുശേഷമുള്ളതായിട്ടുള്ള എല്ലാ പ്രോഗ്രാമുകളും തിരുസന്നിധിയിലേക്ക് ഏൽപ്പിക്കുന്നു. ഞങ്ങൾക്കെന്നും ഇതൊരനുഗ്രഹമായി തീർന്നതുപോലെ ഇന്നും ഇതൊരനുഗ്രഹമാക്കി തീർക്കണമേ. അറ്റൻഡ് ചെയ്യുന്ന ഓരോരുത്തരും വരാനുള്ളവർ എല്ലാവരെയും തിരുസന്നിധിയിൽ ഏൽപ്പിച്ച് പ്രാർത്ഥിക്കുന്നു. ഒരുമിച്ച് ഞങ്ങൾ അങ്ങയെ മഹത്വപ്പെടുത്തിക്കൊണ്ട് ഈ പുതിയ കാര്യങ്ങൾ കേൾക്കുവാനും അത് അനുസരിപ്പാനും അത് മനസ്സിലാക്കുവാനും ഞങ്ങളെ സഹായിക്കണമേ. പ്രാർത്ഥന കേട്ടതിനായി നന്ദി. ഞങ്ങളുടെ കർത്താവും ഞങ്ങളുടെ രക്ഷിതാവുമായ യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Good morning, everyone. Today's quest is implementation science in nutrition support. It is a highly relevant and impactful subject in the modern clinical practice. And while advances in nutrition science have generated a strong evidence to guide patient care, the real challenge lies in effectively translating the evidence to everyday clinical practice. We are truly honored to have with us eminent speaker Dr. Krishnan Sriram, an intensivist and expert in critical care nutrition from US Department of Veteran Affairs Tele-Critical Care Program, Chicago, USA. His extensive experience in the critical care nutrition support has significantly contributed to advancing best practices in this field. Before we begin the session, we would like to felicitate our esteemed guest speaker. May I now request Dr. John Walid Sir, Associate Director of Believers Hospital, to kindly come forward and honor Dr. Krishnan Sriram with the traditional panada as a mark of our respect, appreciation and gratitude.
So do you want me to start? Yeah. Ladies and gentlemen, thank you for being here on a Thursday morning, and I'm happy to share with you my thoughts about implementation science. Now, the learning objectives of my program are, can I change the slides in this one, or? We know the science for many years, but the frustration is that what we know is not practiced actually. There are many reasons why there are obstacles. It may be from your colleagues, it may be from administration, it may be from the patient. So I'm going to talk mainly about how do we implement the practice. This implementation science has been well known in all manufacturing, like car manufacturing, aircraft, and various other aspects. So I'm going to concentrate only on nutrition and to convince those of you in administration that spending money on nutrition has a return on investment. The auditors call it ROI, correct? Our return on investment of 16 to 17 rupees for every rupee you spend on nutritional products, on hiring more dietitians and so on. And very briefly, I'll tell you about how this has been successful in nutrition in this MQII you see here, Malnutrition Quality Improvement Initiative and Effort Study. And depending on the time, we'll go ahead. Now, nutrition is a basic human right. And unfortunately, what is happening is this is not always established truly in all socioeconomic status. One of the reasons I like to come to Believers Hospital, this is the third time I'm coming here, is because of all the good charity work you do. Of course, you have private patients also, but there's a lot of charity, and so that is very important. It's a basic human right, whether it's a villager growing rice or whether it's a CEO of a company, they deserve the same kind of nutritional support in a hospital. And whether it's privately funded or government funded, it doesn't really matter. And here is a nice paper where some of our own folks in India are also authors of this, that there are various things about how you have to respect the patient and how you have to give them the dignity. Just having a feeding tube is not losing a dignity of any kind at all. So, if a cancer patient cannot eat, then you have to put in a feeding tube before you give the chemotherapy or the radiation therapy. So a patient can die of cancer, but they shouldn't be dying of malnutrition. And what is important is we don't need this concierge medicine, like senior consultants who just want to see the rich patients. We don't want the concierge medicine. We want something that can be implemented for everyone. Now, we also have to respect local and individual situations in every geographic area. The National Society guidelines must be actually tailored to local practitioners to some extent. But one thing I can tell you, there is absolutely no need for us to develop guidelines for everything. There are guidelines available in Europe, in America, in Canada, and so on. A common problem I have when I give a talk here is, those are North American guidelines, not suitable for India. And my retort to that is, whatever is the color of your skin or your complexion and whatever accent with which you speak, nutritional physiology and pathology is the same, or nutritional biochemistry is the same. So we have to follow whatever guidelines are available. Of course, it is true that it is somewhat surprising that you have two sets of guidelines, one European and one American, both separated by the Atlantic Ocean, who look at the same literature and come to different conclusions. And the suspicion is it is all industry sponsored, which is quite common in India. A company gets together a group of KOLs, key opinion leaders, who are not KOLs, but they are actually high prescribers. You see? And then they get them together and then say, oh, we have these guidelines, and then it is published in some predator journals where you pay 2 lakh rupees, it gets published. It is not even peer reviewed. So those things we have to avoid, and I'm going to talk a little bit more later to tell you how we can use it. The first point is that there is a confusion as to what is malnutrition. Okay? Different people think differently. Dietitians may think about one way and others may think about another way. For almost 50 years, we've been thinking what indeed is malnutrition. The WHO classifies malnutrition in the community, but the WHO, World Health Organization, does not look at disease-specific malnutrition. I can guarantee all of you are well nourished today. After Jyoti fed me omelette this morning, I'm well nourished, But if we were in a car accident, by evening we become biochemically malnourished. By classification, I'm not malnourished, but just the fact that I am a trauma patient means that I am biochemically malnourished. And therefore, with all these various guidelines, the folks got together in the world and followed what is called the Global Leadership Initiative in Malnutrition to simplify the definition of malnutrition, because it is the reason why the nutritional care of patients are often neglected is because the physician does not realize the patient is malnourished, especially the obese patient. I have known doctors who have snarled at the young dietitians and say, are you crazy? Here is a nice, obese, chubby patient. You're telling me that the patient is malnourished? In order to simplify this, we have the Global Leadership Initiative in Malnutrition, which I am hoping in some form or fashion you are already practicing here. You are, I'm sure. And so the definition is based upon etiologic criteria and phenotypic criteria. The phenotypic criteria are the usual weight loss and so on. the etiology criteria is disease-related malnutrition based upon a nutrition-focused clinical examination, physical exam, which many of your dietitians are very, very good at. If you have one etiologic criterion and one phenotypic criterion, then you are sure that the patient is malnourished. Now, if the patient is malnourished, then you have to definitely do something about it. For example, if in your electronic medical records, and our person who's going to do research on this, oh, I forget your name, you know, if you have pretty soon disease coding is going to start, am I right, in India? Every disease has a code, international disease code. Now, for that disease, there has got to be for that disease or diagnosis, you got to have a procedure. Suppose you have somebody comes with meningitis and there is no treatment for that, that is medical malpractice. Suppose there is suppose you have picked up the patient is malnourished and there is nothing else there to say that the patient is malnourished, there is no intervention, then there is not good medical practice too. So both are linked. Very easy for audit purposes. You know, very soon insurance companies in India and others are going to insist on electronic medical records. It's going to happen in the future. So that kind of thing can be done only by simplifying the definition of malnutrition and making it easy. Now, you will ask me one more thing for this implementation, about which I will talk a little bit later, but I might as well tell you now. What happens if there is a diagnosis of malnutrition recognized by the dietitian or by the nurse or by the junior doctor on the chart? And the physician, the trainee, even a house surgeon, even a medical student tells the senior professor, sir, the patient is malnourished, is scheduled for surgery in a few days' time. The surgery has to be postponed because you must put the patient in a prehabilitation program for 7 to 10 days. Okay? Now, the senior doctor says, who in heavens are you to tell me? You are not even born or conceived when I was already a famous surgeon. What do you do about it? So, what we have learned in US and other places, you write a nice progress note to say, based upon current recommendations, the recommendation based upon society guidelines and practice patterns, we, the nutrition support team, suggest the following. However, if the treating physician does not want to follow this, please justify the same in the progress notes in the event that the care of this patient get audited for legal purposes. This has worked in America, worked in various countries. Immediately the doctor sees that and realizes, okay, I can disagree, but I must justify why I'm disagreeing. And if that patient dies, I tell you, there is no court in the law, in the land, which will side with the physician, because there is a clear-cut thing that no one should have emergency surgery. I mean, not emergency, elective surgery without prehabilitation. So the advantages of the GLIM criteria, it's set up by an international consortium. Therefore, you can't say some other country's guidelines, okay? And it makes it very, very simple. Now, I have mentioned earlier that do we actually need multiple guidelines? As I mentioned earlier, we don't need multiple guidelines, but I'm going to talk a little bit later in my next talk about how you can merge everything and make some local policy. So if you have a local policy in your hospital, then it is easy to justify it, correct? You don't have to put the responsibility on the guideline. The dietitian or the young doctor or anyone or most often the problem are the surgeons, even though I'm a surgeon. You know, everything, it's a surgical team. I hope I don't offend any of the surgeons in this room, but that is the truth. They want to do the procedure right away, not realizing that the patient must be prehabilitated prior to an elective operation. And so, if you bring it into your hospital guidelines itself, hospital policy, then it makes your life easy. It becomes automatic. Okay, anyone going for elective operations, then it is a mandatory consultation with the dietitian. Of course, there may be other reasons where the dietitian may not know, or the junior doctors or the intensivists may not know why the surgery is being done as an emergency, but that has to be justified. Now, they have compared the well-known ESPEN, European Society guidelines about the definition of malnutrition with the GLIM criteria, and they have found that the GLIM criteria is just as good, the GLIM. And so you can really believe in it. And one of the things I've been trying to do is trying to just make sure that it is simplified. Our life has to be very simple. I realize that many of your team and maybe you believe NRS 2002, correct? That is 25 years old, correct? 25 years old. So that has to be modified a little bit to suit our own thing. Now, let me tell you the examples of how we can change. The delays in implementation. Bowel sounds, very, very common practice. Surgeons would say, I've done a GI anastomosis, so I need to wait for bowel sounds and passage of flatus. That practice has been given up 25, 30 years ago. No self-respecting surgeon will carry a stethoscope to listen to bowel sounds for a decision to start feeding. There are other reasons why it should be done. Completely given up. Very, very common practice. Now, also, this implementation science will not only involve nurses, will not only involve surgeons and physicians, but also nurses. So, in nursing school, even now, the bowel sounds are taught. Not only that, I'm sure some of you are nursing students over here, or maybe nursing leaders. 4-quadrant bowel sounds, which makes me laugh a little bit. This is one big quadrant in the abdomen, correct? One big segment. What's the point of doing 4-quadrant bowel sounds, you see? So there is no reason at all. And so the nurse I have known in some hospitals in Chennai will tell the patient, what nonsense is this? Here is a young doctor coming from America, thinks he knows everything, you know. In all my years of practice, I have never given feeding to a patient where there are no bowel sounds. So I'll tell the patient, you go and tell the doctor that you're having abdominal pain or something. So you see, this implementation of good practices must involve the entire team. Everybody must know what to do. Another problem is GI anastomosis. I've done an anastomosis, therefore no feeding for 4 or 5 days. That practice has also been abandoned. Those of you who are familiar with gastric surgery for obesity will know you do a procedure called gastric sleeve resection. The entire greater curve of the stomach is cut and the patient is fed in 2 days' time. The colorectal surgeons are very good. After a colon surgery, rectal anastomosis, patients are fed with clear liquid the same evening or the next day. If the rectum, my friends, can stand stool going through, why would not the stomach stand the secretions of the, and a little bit of feeding? Now, feeding the patient with anastomosis doesn't mean a big masala dosa and biryani and, sugarcane juice. It means 500 cc's of a scientific formula. That's all it needs. And I'm going to show you some more evidence of that. It's 500 cc's given the total volume in the small bowel of 6 to 7 or 8 liters. Then gastric residual volume. There again, there's something you can do. There's no need to check gastric residual volume for feeding ICU patients before every feed. No need at all. It can be abandoned, except in some conditions about which we'll talk about. Parenteral nutrition when not indicated. One of the most abused medications which I have noticed in many Asian countries is parenteral nutrition. There is no reason at all to give TPN to a patient at 4,000 rupees a shot when you can feed them enterally. And micronutrients are often forgotten. Every time you give TPN, you should add trace elements into that. So now you might say, we are still in the infancy in India. Not so at all. Here's a study from Belgium that showed even a few years ago, 2021, about 5 years ago, on 300 patients, all the guidelines were followed, but the patient was not getting enough calories and protein. And there was a greater deficit in protein, and you know that protein is also very important. Now, this thing about GI anastomosis, you might think it is strange I'm talking to you now. This paper is from 2001. 25 years ago, this paper has very clearly stated that anastomosis heal better when you feed the patient. And yet 25 years later, it has taken us this much time, correct? And here's another paper in a surgical journal to say patients with nasogastric tubes in the first 24 hours are at increased risk for aspiration. So, you know that we can drink a lot of water and eat and step down into a river and drink water. You see, we can drink water because the gastroesophageal junction and sphincter is strict enough. But if you have a feeding tube through that, especially the stiff Riles tube, the polyvinyl chloride stiff tube, the sphincter becomes incompetent. So you have a greater incidence of aspiration pneumonia if you have a nasogastric tube. So it is said there very clearly in 2002, you don't need routine NG tubes, and then this was quoted again, during the same time, 2001, but yet we are still following it. Repeated the statement 3 years later in 2005, 20 years ago, that routine NG decompression does not accomplish any of its intended goals: return of the bowel function, preventing pulmonary complications, and the risk of anastomotic leakage. Okay, guys? So now, let's see. Gastric residual volume has no relationship with aspiration pneumonia, and it's very clear in this paper in Journal of the American Medical Association, one of the most prestigious journals in the world, that there is no reason to measure because there's no effect on organ failure or mortality. But here is another study, both in a private hospital and in a university hospital, although it is limited to mechanically ventilated patients, and even in a group where the risk was felt to be high, it is not necessary to guide enteral nutrition. It is okay for other reasons, but you don't have to keep on measuring it. And more than anything, my nursing friends, don't take that aspirate and shove it into the garbage bin or into the toilet bowl. You might think it looks yucky, but actually, in my mind, it is loaded with zinc and selenium and bile salts and growth factors and all that. We have 1.5 liters of saliva loaded with growth factors. That is why animals lick their wounds to make the wounds heal better. So, some cases you might, if you are still measuring gastric residual volume, the nurses will tell you 400 cc's is too high. 600. So you can gradually, instead of going from a 500 cc gastric residual volume to 0, you gradually bring down your threshold. And that is the way to do it in all implementation science practice. Here is another study that shows that it does not make any difference for emesis, diarrhea, or glucohomeostasis, and elimination of routine measurement had no effect at all on the adverse effects, and the patient got more of the prescribed calories. Here is a paper from one of the Scandinavian countries, where after pancreatectomy, and especially classified under major upper gastroenteral surgery, normal feeding. I totally agree with you. You don't give them the proverbial masala dosa and biryani after a pancreatic surgery. You start them off with liquids, and then the patient will tell you what they want to eat. See, that is the most important thing. You don't need to really actually wait. Here is a systemic review published again in 2023 involving 50,000 patients, and clearly showed that early enteral feeding decreases anastomotic leakage, and early enteral feeding decreases mortality and overall complications, length of stay, and infections. So for those of you who are interested in more of this, I'll hand over the slides to you, Jyoti, and then you can share it with anyone that you like, because I believe a lot in train the trainer program. After I leave and go, you can give the same talk to someone else. Now, what is the reason why there are differences between evidence and practice? As you can see in the Hines pyramid, from low-level case reports, you gradually go up and up and up the pyramid, the Hines pyramid, and then you come across guidelines. You see, but even though people know guidelines, what are the reasons for that? It has been classified into physician factors, systemic factors, that means hospital administration, about reimbursement, and the lack of uniformity of guidelines. You take reimbursement, for example, insurance companies will gladly pay for 4,000 rupees of parenteral nutrition, but they won't pay for 100 rupees of enteral feeding. That has been circumvented thanks to the Indian Society for Critical Care Medicine and Indian Society for Parenteral Nutrition by lobbying the insurance companies. It gets classified as a pharmacy item. No longer will it come under the dietary department. So as long as it's a pharmacy item, insurance companies will pay for it. How ludicrous it is, 4,000 rupees for a TPN per day, including all the devices that you use, lab testing and so on, when enteral feeding can be given for just about 1,000. About 100 rupees a day. The physician factors are clinical inertia. Well, it takes too much time. I actually follow the guidelines. I actually follow. You audit that physician's practice, it is not so at all. So self-reported feeling that I, as a physician, am following the guidelines, but actually that may not happen. And then it's a disagreement within guidelines, which I'll have told you, and the perceived conflict. Oh, I've been in practice for 20, 30 years. How come, how can some new guidelines tell me what to do? Okay. So here again, a true story. One of my dietitians, during my long career, I worked in Chennai in Tamil Nadu Hospital, which was a US style hospital, for about 12 years there. And there was one cardiac surgeon who was arguing with our dietitian. Okay. And he said, oh, how can you tell me what to do? I'm a US board certified thing. The dietitian boldly told the cardiac surgeon, but sir, you did your residency and fellowship 15 years ago. Concepts have all changed. Okay, concepts have all changed. So please listen to me. It was something very simple. A post-cardiac surgery patient could not come off the ventilator. The dietitian, because I make them write down drug-nutrient interactions for all patients. One of the drugs the patient was on for GI prophylaxis was sucralfate. Sucralfate causes hypophosphatemia. It is because of hypophosphatemia that the patient could not come off the ventilator. So this surgeon is saying, who are you to tell me I should check the phosphate level? I don't believe in it. No, sir, you must do it. Okay, so the phosphate level was something like 0.5. Lethal, patient could have died from that. And after that, this cardiac surgeon never would eat out of the hands of the dietitian because she proved her worth. You see what I mean? So it is extremely important that physicians must realize that I'm not the expert in it. Very much like if there's a mechanic in Cochin Airport can prevent takeoff of a 747 pilot by just saying, I found a drop of oil on the ground and therefore the plane is not ready for taking off. Likewise, a dietitian or a young doctor or whoever is doing the nutrition screening, by hospital policy should have the right to prevent an elective operation from being done. Okay? And here in the bulletin of American College of Surgeons 20 years ago, occurrences suggest that intuition, personal experience, physiologic reasoning are totally impossible to convince doctors that this is what you should do based upon present guidelines and in the new concepts of disease and thing. So I want to introduce you to the terminology of intervention science. Would you believe the gap between evidence and practice is 17 years? Would you believe that? Here is a paper from the prestigious Journal of the American Medical Association. 17 years. I showed you examples of how bowel sounds and all that were practiced many, many years ago. So it is not a gap, it is a chasm, a huge valley where evidence is not done at all. Now, this has been shown in non-medical areas also, in community medicine, in management of hypertension. So most of the research done now, there is a move that 10% of the money spent must be spent on educating the methods by which science can be implemented. And unfortunately, 80% of research is only to boost up the CV of the person doing it, not to benefit the patient. What we want to do is we want to benefit the patient. And here is a beautiful paper, which I'll send to you if you want, showing implementation science specific to nutrition from research to practice. And this was published just about 5 years ago. In the framework of of implementation science, there are several publications, and I hope you can read that, the query, QUERI, and I'm going to talk only about those two arrows that you see there to show you that this can actually work. Can you see the slides all right, sir? Or you can come over here. Yeah, okay. So in the query, there are several steps that you can see here. First of all, QUERI is Quality Enhancement Research Initiative. This has been published already. And it says you identify the high-risk patient, you identify the best practices. Why are the best practices not being followed in my hospital? How can I change that? Who are the stakeholders and how can we get everybody together? And the description, I won't bore you with all the details in small print there, tells you exactly how you do that, but set yourself a time limit. You can't say I'm going to do it 6 months from now, because in the 6 months, patients are going to die when the good medical practice, good nutrition practice is not done. The PDSA is something simpler. What are we trying to achieve here? We are trying to achieve recognition of malnutrition. We are trying to achieve early feeding. We are trying to achieve a system by which every patient coming into the hospital for elective surgery or for elective chemotherapy or radiation or any major intervention procedure, you should try to, that is our plan. You test your plan on a pilot in certain areas. You test it. For example, in one hospital in Bangalore, they checked the ERAS protocol, early recovery from surgery, early recovery after surgery, and also the GLIM and also the prehabilitation in the orthopedic department. Now, does it surprise you? Orthopedic surgeons don't deal with the GI tract. But even if they are dealing with bones, absolutely nothing to do with the GI tract, by the prehabilitation and early feeding of the orthopedic surgeon, the patient goes home sooner with an artificial hip or after fracture management. Then test your plan in one unit, and if it works, then you go to the other units. And what can be changed in my hospital is called the PDSA kind of thing. Now, is it cost effective? Cost effectiveness has been shown very, very easily with prehabilitation, early nutrition, enteral feeding, oral nutrition supplements, about which I'm going to talk about, and post-discharge. When a patient goes home, my friends, there is sometimes a physiotherapy visit to the house. The nurse goes home to the house. But how often do the dietitians do that? Correct? Maybe never. You don't need to go to the patient's house, but you can use it on a cell phone. You know, as the government says, there are more cell phones in India than toilets, you know. So you can do all this with the cell phone itself, calling the patient. Did you take your supplements? Did you do this? And then the formation of teams. So this, the extreme importance of prehabilitation prior to an operation is also by telenutrition. So sometimes, I'm sure in your hospital too, there are physicians in the surrounding area. I'm told you get patients from 200, 300 miles away. So how are you going to give them prehabilitation program? It can be done by telenutrition. And it includes telenutrition, evaluation, involves also a lot of things like physiotherapy, nutrition-related physical examination, and it should also be continuous 30 days post-op. And this is another study that shows it is cost-effective, decreases morbidity, and unplanned readmissions are avoided. So here is an extremely nice paper to show that prehabilitation works very well with major abdominal surgery. Now the figure shown of $22,000 per patient is not applicable to India because costs are all ludicrously high in the US. You know, an echocardiogram that costs 500 rupees here will cost $5,000 in America. So it's not applicable. But the principle is very clear. You see, there is a decrease in complications when you put the patient into a prehabilitation program. That doesn't mean somebody coming for a routine hysterectomy or a hernia operation or a gallbladder operation need to spend the time and effort on this. Any major abdominal surgery needs to be done. Cancer is very important. Here is an absolutely beautiful paper using the nutrition care process model. Nutritional prehabilitation must be applied to the preoperative oncology patient. Very, very important. Many oncologists, our great oncologists agree, but they don't think about nutrition. Okay, they don't think about nutrition. Now here again, I'm not slighting oncologists, but they should also believe the dietitian. I'll give you two examples of how I prevented some major disasters recently. So a relative of mine goes for rectal surgery, and post-operatively, the oncologist puts them on a so-called cancer enteral product available in India. Cancer-specific products, as I'll mention in my next talk, have been given up in the US, but here it was done. Then I looked carefully at the formula, and in the formula, it said there was something like an algae from the sea. So I called the company guy, very reputable company, his name, and what is that? No, sir, there's a lot of research to show that this algae is very good for cancer. Oh, is that so? So I did a PubMed search. There are 25 references. 20 of them are animal experiments. Okay, 20 are just animal experiments. 5 of them are human experiments. But if I tell you, you'll smile. The human experiments are they took the cancer cells, put it into a petri dish, and then put this nutrient, and the cancer cell in a dish, the growth was thwarted, and now lo and behold, it is now in a cancer product sold in India, but not regulated by the government. Why? This is not a medication. If we cannot even regulate the use of approved medicines, how are we going to regulate nutritional products? Okay. Now, worse still, this oncologist said you had major surgery, your digestion may not be very good, so I'm going to give you a tonic. This tonic marundu is not used anywhere else in the world, but our patients demand it. And I looked carefully at the thing. It had, guys, you'll get scared. It had a fungus called the Aspergillus cerevisiae. Aspergillus cerevisiae is a fungus that is added in Malaysia and China to bread to facilitate fermenting. Aspergillus fungal infection in an immune-compromised patient, would you believe that? And you take this and then you're going to get Aspergillus infection and then you're going to die from it. So how can an oncologist keep track of all that? Only by trusting the dietitian to do that. Okay? So let me proceed further. I have about 10-15 minutes more. Now I want to share with you my talk about oral nutrition supplement. Now what we did was we did a study in Chicago based upon this Philipson study where they looked at 44 million encounters to see whether a patient got oral supplements or no. That's all. And they found that very few patients got oral supplements, but in this study they showed that if an oral supplement was prescribed to a hospitalized patient, the chances of that patient getting readmitted for any other reason was less. So they found there was 6.77% decrease in the readmission. So what we thought of was what will happen actually if we actually do something differently. Let us make sure that all aspects of nutritional care are covered. And this paper was published in the Journal of Journal of Parental and Enteral Nutrition. Now, this earlier paper showed that ONS use in the community produces overall cost benefit. Another paper showed in the hospital setting is also cost benefit. So in my study, what we did was we made sure that all patients in a hospital got oral supplements, and we found that the cost was about $5 million or less, and the length of stay went down by 26%. Would you believe that? 26% unplanned readmissions were down. And what is surprising in this study was that if you give oral supplements for 30 days in the hospital, up to 90 days the benefit was felt. Up to 90 days, the chances of the patient getting readmitted to the hospital was less. And this study has been replicated at least 15 times in other studies also. It is not a one-time study. So all patients in a hospital who are diagnosed to be malnourished, either medical or surgical, get an oral supplement. An oral supplement does not mean one of the 100 bogus products available all over Asia and all over the world, but a good scientific formula. And here are other examples of replicating studies. I agree with you. You won't be able to go through each one of them, but I'll be happy to share the slides with you. The enhanced recovery from surgery is something that I know you are practicing in your hospital, early ambulation, early enteral feeding. And some people ask what is actually the difference between prehabilitation and enhanced recovery from surgery. So here is a paper to show that enhanced recovery after surgery for colorectal surgery is very good. And it is very cost effective, less medications are used, early resumption, and in different specialties in many countries it is used. There is also a paper to show that the prehabilitation works in low and middle income countries, published in the Lancet. Now, final part of my talk is about teamwork. As you know, interdisciplinary teamwork is extremely important, and dietitians play a very crucial role in ICUs. And appropriate enteral and parenteral nutrition is used. Dietitian-led quality improvement work optimizes nutritional care, and it preserves muscle strength. The goal of the dietitian is all to preserve muscle strength. And this statement made by the Society for Critical Care Medicine clearly shows that dietitians form a very, very important part in the management of critical care patient. And here is a position paper that I wrote with Gail Cresci, who was the president of the American Society. the person who's most knowledgeable in that. Sometimes some dietitians are even more knowledgeable than some of the physicians in electrolyte correction. Not that the physician doesn't know, they didn't have the time to think about it. Okay? And suppose you don't have a formal team, it doesn't matter. This paper from Aspen, American Society, shows that if you don't have a team, it doesn't matter. You call it an interdisciplinary team. So instead of your personal opinion, the responsibility can be put on to the team. Now, interprofessional education is something very important. That is, non-technical skills can be taught. For example, the dietitians are not allowed by law to put in feeding tubes, but they may know how to do it in somehow because of the licensing thing. So, but the dietitian can say, sister, I have this nice video, would you like to watch how to put in small bore feeding tubes? The small bore feeding tubes, which is the tube that you should use for feeding, not the stiff tubes. So the sister will say, no, I know how to do it. No, sister, just look at it, you know. And then, so even non-technical skills can be taught by anyone else in the department, because it's sometimes a little bit difficult to for a senior physician to do everything, including putting in a feeding tube and so on. Now you might say, oh, I haven't established a team. Don't worry, my friends. This is a paper that was published in 2005, which showed that even in European hospitals, you'd find that it is not perfect. So it doesn't matter. We don't have to feel bad that we are not doing everything perfect, because this paper also shows that in any country, nutrition care has always been a problem. Here is a study that I did many years ago in Chicago about reorganization of the nutrition support team. And without belaboring the point, we looked at, is the parenteral nutrition appropriate? Has every effort being made to provide enteral feeding? Has every option done? Has the nutrition support team been consulted? And who's paying for it? Is it the insurance company? Is it the patient? And then in this study, we found that in a public teaching hospital, by improving the function of the team, by cutting down the lab tests for monitoring, and by looking at quality improvement products and working through the students and residents, rather than picking up the phone and calling up senior consultants, you work through the students and residents to pass on the message. We have actually found that we replicated a study done in the UK, where it shows that the Royal Exchequer can save 26,000 to 80,000 pounds per year. And friends, it is from 1992. In today's money, it will be so much. By only having a dietitian, qualified dietitian, in every hospital. This was called the King's Fund report. So after that, in UK, they have said that dietitians' role have become very, very important. And the cost effectiveness of teams has also been shown in many of these other papers that are listed. The only reason I'm showing you this slide is, it is not my view, but it is the view of all this. Now, there are several barriers, after which I'll stop my talk. There are multiple conflicting guidelines, the lack of sensitivity to the differences in geographic region, the accessibility for free information, which is quite easy now. Many papers now are available online. Another trick I can tell you is they usually give the email of the doctor or the main author. You write to that person directly and say, I'm not able to do this, and be frank and say, I'm not able to afford $35 multiplied by today's exchange rate, multiplied by 90. Who in heavens is going to pay 30,000 rupees for one paper? Tell me. Of course, the other alternative is you send me an email and I'll send it to you. You see? So, accessibility to journal. And there are a lot of mega journals, these predator journals, which are absolutely useless journals, but beautifully written. So, you have to expand virtual conferences. For example, you can have, a talk like this can be videoed and put it on your website so that others can also see. But it's mainly cultural. You see? For example, nil by mouth after midnight. That practice must be abandoned. Nil by mouth after midnight for a procedure being done at 12 o'clock in the morning. Why in heaven should the patient be nil by mouth after midnight the previous day? So I have spoken to anesthesiologists and said, your own society say it is not necessary. 4 hours is fine. See? But it is still a problem all over the world. In children, they scream the head off in the morning, so children are fed 3-4 hours before an operation. So you can give solid food up to 6 hours prior to an operation. But when you polled them and said, why do you not change the practice? The answer is always it is cultural. Similarly, in medical school education, about which we cannot do anything, but you can do it being a private university. In your medical schools, your MBBS students must be taught the importance of enteral and parenteral nutrition. Most of the teaching is community medicine, but not actually hospital-based disease-specific nutrition. And of course, empowering non-physicians is what I've been talking about in many of my talks, and accountability. But in accountability, you have to understand that the fear of medical malpractice doesn't improve the care of the patient. So don't feel bad. This paper shows in a US hospital, training in nutrition is pathetic, very, very poor. So it is the world over. We have not been able to change it in India because the medical council will not allow to change it. And if you give them lectures, the first question the medical student will ask is, am I getting any questions, multiple choice questions in my final exam? If it is not in the final exam, they're not interested in learning about it at all. They're not interested in feeding tubes and all that. Okay? But there is a shortage of physicians interested in clinical nutrition. You see all these different societies on the left, they've all said that we don't have enough doctors who are specifically, who have a passion. And I'm sure in your hospital, you have 1 or 2 physicians. It may be a nephrologist, pulmonologist, intensivist. Usually it is intensivist in every hospital, you know, who has a special interest in nutrition, who becomes the team leader. So if you have obstructionists, then the dietitians or the junior doctor can call the doctor and say, will you please call that consultant and say, this is not the right practice, would you do that? And for that, you need protocols. And it is only by protocols that you can actually improve the medical care. The Academy of Nutrition and Dietetics is a new name for American Dietetic Association. And they have the malnutrition care workflow. Workflow means from beginning to end, you know, from prehabilitation to the hospital, then you have this intervention or implementation science. You need to have the whole gamut. And these are the 2 trials I've told you. One is the effort trial. When I send you the paper, you can go through this and see what the effort trial is. And then the other one that I have to tell you is the cost effectiveness study, okay? And I mentioned about accountability. It's very important that physicians have to remain accountable, and fear of medical practice does not improve the quality of care. So the last slide I'm going to show you is the disruptive or the unconvinced physician. What do? You go up the chain. You go up the chain. Let's say a physician says, no, I don't want to do that. Then who are you to tell me? You are a junior doctor. You are a dietitian. Then what you do is you go up the chain. And then you go up to the management level. We have seen this happen in other places also. If the management does not support you, then it's a losing battle. You can't do anything about it. Okay? The medical records, everything must be documented. As I mentioned earlier, it is okay. Just write down why you are not following these guidelines which are based. And a direct approach. So there are 2 ways of doing it. Suppose you have a co-worker who is fighting, not very good. There are 2 ways to handle it. One is you can go to your superior and say, I'm having problems with this co-worker. But all the management, MBAs will tell you that's not the way. Okay? You actually go to the co-worker and say, look, you know, you're being very disruptive. And majority of times it actually works. And then you must be armed with all the guidelines, you know. You say, that's not my view, not my personal view. You know, I forgot to tell you at the very beginning, which I tell you in, which I mentioned in some of my lectures, which I'm sure you wouldn't do. Please don't throw tomatoes or rotten eggs at me. If you don't agree with what I'm going to tell you in the lecture, but I didn't have to say it because I know you're not going to throw tomatoes at me. And then through patient advocacy, that is, an educated patient these days will ask the doctor, you know, doctor, I'm going to have this major pancreatic operation. Am I going to be part of the prehabilitation program? You know, patient advocacy. Patients get involved. And many patients are actually doing that. If the surgeon says, no, I don't believe in that, I say, I'm sorry, I'll go to some other doctor. That's all, as simple as that. Maybe that patient may not benefit, but the next patient will. And then there are various examples how to write sophisticated notes without antagonizing anyone. So friends, it's exactly 45 minutes, and I'm going to stop right now. And I'm going to open the floor for discussion. Okay, thank you.
Thank you, sir, for the insightful session. So, anybody has any questions to sir?
Thank you for a wonderful talk. I'm Dr. Arunima, the recently reintegrated breast oncoplastic surgeon in BCMCH. So back in 2023, Dr. Jyoti had tried to introduce this term prehabilitation in one of our breast CMEs, and that has worked wonders in our area of work, and it has actually made us familiar with the concept that I am basically focusing on emphasizing daycare surgeries for breast oncoplasty and this thing. And when a patient is prehabilitated, it works wonders in their recovery and things. So this talk was very insightful, and it is some practice that we are trying to incorporate, as well as I'm sure it is already there. There are other teams as well, the PMR and the palliative medicine team, who's trying to advocate this practice, making it easy for our surgeons to help our patients out of the perioperative period. Thank you.
Yeah. So now that this has worked in breast surgery, which has absolutely nothing to do with the GI tract, absolutely nothing, when it is implemented elsewhere, okay, when it is implemented in other departments, whoever is bringing it up can actually tell the thing that, look, it has worked in the breast department, we should do that. And then finally, when you have all the stakeholders, you'll find it becomes hospital policy. No longer is it a strange thing. See? Yeah. And also, when it becomes a hospital policy, then sending the patient for the prehabilitation. Remember, prehabilitation means also, it also means physiotherapy. In breast surgery, when I was doing breast surgery, we used to train patients how to go up the wall to prevent stricture after a mastectomy, you know. So a lot of things can be done ahead of time. Smoking is another problem. Of course, it's gone down in many things, and women may not smoke very much. Smoking cessation, psychological counseling, and but palliative care we'll talk about next. I'm a big proponent of telling the patient the truth and making sure that they have settled their affairs before every surgery. Good, thank you very much.
And this, in no relation with GI, basically, like you mentioned, the cultural factors in nutrition plays a big role. So for us, breast cancer patients who get really, they compromise on their nutrition just with the news. So when we emphasize on having a good diet and improved diet before the surgery, that has also played a good role in their recovery.
Yeah. Thank you very much. These cultural factors are extremely important, because suppose a woman finds a lump, she will go to a non-MBBS doctor, okay? Or sometimes they go to a religious head of any religion, okay? And somebody puts their hand there and says, "Oh, don't worry, I'll cure it." Now, if you go to you'll say, "I need a diagnosis first." You'll do it scientifically, okay? Then, worse still, which is the truth, the patient's family will say, no, I think this is only an ordinary lump. I'll send you to a dietitian. So the dietitian would, not all of you guys, don't get offended, you know, would say, "Oh, yeah, I have some breast diet. You know, I have a lot of patients with PCOS. I put them on a PCOS diet, nothing like a PCOS diet. Okay, I will try to resettle your menstrual cycle by seed cycling. Depending on the menstrual period, we give seeds this way. Absolute nonsense. And then the poor patient comes to you 2 months later, correct? They keep on delaying it. So I am brutally honest when I was doing this. I tell them to the face, you know, brutally honest. Do you want to live longer or do you want to die? Some of the patients I operated on 25 years ago are still alive. Of course, I don't do breast surgery anymore. Thank you very much. You already have a team leader here, Jyoti. So prehabilitation in other departments, you know, colorectal, everyone. Okay, it can actually start. That is a big achievement, actually. Yes, sir. I'm sorry.
I have I'm
Yes,
Dr. Rita in the Department of Community Medicine. Done a lot of implementation science research in cancer screening. My question to you, I know you mentioned if administrators are not supportive, you can't do anything. So can implementation science research, my question is, can implementation science research help in that? Because implementation science research, the principles are you look at the barriers and facilitators for any intervention. I looked at screening any intervention. The barrier is administrators are not supportive. There are various ways of getting that support because that is a big barrier.
Yeah.
That big barrier. But now she said she's very happy with Jyoti, and generally administration here is very supportive. It's happening. But if administrators, so we should, I would say, do you have any, and I want to ask you, any experience in doing research where they were not supportive by collecting their information? There are a lot of ways, framework, and then some sharing with them the positive results in various institutions. We were able to get the support.
Yes.
Is there anything that's
sure.
what I just want to ask you.
So that is actually a brilliant question which has affected my life also. So for a moment, I want to tell you, some of you would have heard about the famous American author John Steinbeck. His book is From East of Eden. In 1953, when I was a 3-year-old child, he got the Nobel Prize. He says in the book, the best way is to approach the person directly. If you find a relative who is nasty, you tell the relative, you are being nasty. I don't want to have anything more to do with it. Similarly, in the hospital, you can't go and tell a physician, you are an idiot, you're not following it. You can't do that. So there are two ways. One is, if you send them an email or an attachment or a printed copy with all the guidelines, nobody will look at. You have to set up a personal meeting in privacy. That's the first step. So I have learned that you have to confront the non-believing physician. We are in believers' hospital, correct? We are not non-believers' hospital. You confront in the private side, not when all the residents are looking. Okay, I'll give you 2 examples where this has worked for me and others. One, there was a surgeon who told our fellows and dietitian, I want to limit protein because if you give too much protein, you will get renal failure. Absolute nonsense. Just giving more protein doesn't cause renal failure. So I called that doctor and said, listen, you are a robotic surgeon and all that. You are technically better than me, but you don't know anything about nutrition. Okay? Don't argue. If you do not listen, I'll go to the medical director, and the medical director is your buddy, all in private. And if he doesn't, I'm going to report you to the State Licensing Bureau. That system doesn't exist in India, correct? In the US, even the person cleaning the bathroom can send a complaint about a surgeon, or anyone. That won't work here. So that is the thing. And then he came back 2 days later and said, I'm sorry, I didn't keep up with the literature. I won't do it anymore. Okay? Another example of direct thing is, during the AIDS epidemic about 40 years ago, there was an AIDS specialist who wanted to give a patient 4,000 calories to begin with, an AIDS patient with a feeding tube. You and I know you can't give 4,000 calories. You'll produce refeeding syndrome and the patient will die, correct? So the dietitian said, no, madam, we can't really do that. She insisting, I'm a famous person, what do you do? So they called me. So I went to the medical director's office and then had a phone conversation with her and told her, Dr. So-and-so, you may get the Nobel Prize for AIDS research, but you're not the expert in nutrition. This cannot be done. Okay? If you still want to do it, go ahead and do it, but please remember that we will not follow the patient anymore. We are not legally liable for the care of your patient. And that worked. You see, you have to confront. Don't feel delicate because you know you are right. You know you are right. Okay, and then eventually most administrators will care very much about the publicity of the hospital. You see, of course there is a financial part also. I agree with you. There is a financial part. We have to make sure. But prehabilitation doesn't cost that much money. See? And if you confront folks on a one-to-one, invariably you will be successful. That's what I feel in my opinion. I hope I've addressed that. But when you want to speak to an administrator, don't send your youngest trainee. You go yourself.
Yeah, I was just only trying to highlight, so that's a methodology that you followed. we may have different methodology.
Yeah,
I
different
just want-
methodology, you know. Sometimes first by writing, you know, first by things. But the most important thing we have learned is you cannot legislate. You can only educate. You see, suddenly an administrator can't bring a blanket rule and say, this is what you have to do. You know, that will produce a lot of antagonism. It has to be done in a stepwise way. You had a question? Yeah.
So thank you for that very informative talk. We do appreciate the vast experiences you had, and the talk has enlightened us all. As a token of our appreciation, may I invite Dr. Rita, who is the HOD of Community Medicine, to give you a
Sure.
token of
Do you
appreciation.
want me to stand here or come down?
So you can.
I told Jyoti not to give me any presents.
Thank you. So we'll call the quest for this day. We'll see you for the next quest next Thursday. Thank you.
Thank you, sir. The healthy snacks will be served outside the hall. And a gentle reminder regarding the main session of the day. The CME session will be starting by 9:45. May
Can I
kindly
put this?
request all the
Can you just
registered
note my-
participants to be seated in